Hello, everyone, and welcome to today's call focused on Jewish-Arab relations in Israel's medical system. Thank you so much for taking the time to be with us today. We are living in jarring times where attention is focused in all directions. Just this morning, we woke up to the news of 5 murders overnight in Arab society, which is part of the enduring insecurity within Arab society in Israel. We know that Israelis are wondering every day when and if a strike on Iran and its retaliation will happen. We are living in a time of huge governance and policy changes in Israel and the US, and it's an election year, meaning that we're subject to even more heightened and divisive discourse. So amid all of these uncertainties and all these distractions, we thought it was very, very important to continue to focus on the role of major institutions in Jewish-Arab relations in Israel. Major institutions serve as a backbone for Israeli society in their own way. They provide essential services, stability, and leadership, and a way forward in a way that has garnered renewed attention since the fragile ceasefire and efforts to look towards rehabilitation. In the context of Jewish-Arab relations in Israel, the medical field has long generated significant pride as an example of successful Jewish-Arab partnership in the workplace. Today, roughly 40% of healthcare workers in Israel are from Arab society, which has been growing over the years and providing proof that Arab citizens can study and find meaningful work in the field. Even before October 7th, this success case was still a work in progress. The last few years of war, however, have sown mistrust and polarization between Jewish and Arab citizens throughout Israeli society, and even in those places where partnership was a norm, contact was frequent, and spaces were shared. Today, we will be looking at how this polarization impacted Jewish-Arab partnership within the medical system and how the system may be able to build on its past successes and model ways of absorbing and mitigating these shocks in the future. We'll be asking what interventions can strengthen stability in the system and mitigate risks that such tensions present to health outcomes. In the wake of the ceasefire, and the renewed attention to rehabilitation, a number of efforts have turned to the issue of Jewish-Arab relations in the medical system. Today, we will hear from leading doctors and researchers to shed light on how civil sector organizations are working together and doing research to tap into this potential. Here to share with us are Dr. Abeer Suleiman, a gynecologist, director of hospital development at Clalit Health Services, and founding CEO of the Forum for Health Promotion in Arab Society. We have Yana Neumann, Director of Shared Workplaces at the Arab Abraham Initiatives, and Dr. Manal Hreib, who is Director of the Negabia Research Center. And I am Liron Shoham, Director of the Task Force on Arab Citizens of Israel. We're really delighted to have you all with us. Our 3 presenters will give us insight into current realities in hospitals and the findings that their research has provided, and what implications they have for future interventions. To start us off, I want to welcome Abeer Suleiman to tell us a little bit about what it's been like in the medical system. Abeer, welcome.
Thank you.
You've been practicing in the Israeli medical system for more than 20 years. Can you tell us a little bit about what it's been like to be an Arab doctor in Israel before the 7th, and then how things have changed?
Okay, so I joined the medical or the health system as a student in the Technion at 2020. Hearing me?
Yes, we hear you.
Okay.
Thank you.
If everybody who is not speaking can please mute themselves, and then we can hear Abeer clearly. Please, Abeer.
Okay, so I studied medicine at the Technion in Haifa. I started at 18 years old, and this was the first meeting with the Jewish society. It was comfortable years. I had a lot of friends there. We have a lot things to share, to do, to study together, and I grew in a peaceful health system. The Israeli health system is known to be a peaceful island of coexistence and partnership between Arab and Jewish people. We work together, we eat together dinners, we drink our morning coffee together, we share our personal details at night shift. We have a wonderful friendship as Arab and Jewish, but this relationship may be sometimes fragile relationships. We got through a little broken relationships during military operations or security events. When we go back to that Arab health workers are Palestinians. And when there is some conflicts between Israel and Gaza or Israel and Jenin, we feel some changes, negative changes in the relationships. But these changes were temporary, lasted for a couple, 3-4 days, and we return normally to our peaceful relationships and partnership. But the 7th of October, and because it was an awful event there and the massacre, it was something so painful and terrible that keeps us or kept us all with no words in our mouths. So it led to maybe a harm to this relationship, and this relationship were broken deeply and profound polarization between Arab and Jewish people in the system. Arab health workers, because they are Palestinian, they felt that they are accused of what happened on the 7th of October. They had no word to say because these feelings, and because they didn't know what to say, because they are part of the Israeli society. So there's nothing to say about the awful things that happened. I think all of us felt the same sorrow and the same sadness at like all the country and all the Israeli and Jewish people felt. But when because we, or some of us, didn't speak up and didn't express his sorrow and sadness, Jewish colleagues understood that this is agreement with what happened on the October 7th. There was an understanding, and this worsened the relationship between the Arab and the Jewish health workers. Arab workers felt so unaccepted. They felt anxiety and fear and non-secure in their workplaces. Some got fired because all the posts on social media that didn't relate it to the war. People who, for example, had a post that he wrote Allahu Akbar. Allahu Akbar is a phrase of prayer. Our 5 prayers in day, we says Allahu Akbar, but it understood like acceptance and acceptance of what happened of October 7th. So people people were or people searched for such all the posts on social media, and Arab people, even doctors, got fired from their jobs. Arab people didn't allow, or Jewish people didn't like that Arab workers express their sadness or sorrow for killing children in Gaza or bombing hospitals. They forgot that we are part of the Palestinian nation. We are Israeli, and we are proud of being Israeli people. But on the other hand, we are part of the Palestinian people, and it's such a confusion with our identity. We feel the sorrow of the both sides, and we feel the love and the acceptance of the other side, of the Palestinian people and the Israeli people. And in such cases and events of conflicts between Israel and Gaza, or Israel and Palestinians, we are broke into these conflicts.
Abeer, just one or two more sentences, if you can tell us. So now we are, after 2 years of war, months into a fragile ceasefire. Are there things, are relations still tense in the hospitals?
Yes. The relation still tensed, and we didn't go to the 6th of October yet. We didn't go to that. We need to work hard in order to go there, because people didn't talk about this. People didn't share their thoughts, their feelings about what happened. So Jewish people remain thinking that Arab people accept what Hamas did on the October 7th, and Arab people think that Jewish people accuse them because they are Palestinians. And because the two sides didn't talk about this and didn't clarify their positions and their thoughts and feelings, the relationships has not being normal yet.
And I know we're going to expand this with you later, but I know you speak a lot about the impact on health outcomes and the ability to work together under such tensions.
Mm-hmm.
I want to invite you to come back with that later. I also want to invite anyone in the audience to start plugging questions in chat. We will have time for Q&A. Thank you, Abeer. I want to now move to Yana Neumann, who has been conducting research on the phenomenon of the tensions in hospitals, along with Dr. Manal Hreib. Yana, what Abeer shares is something you've heard from lots of doctors across the medical system in your research. How did this escalation in tensions over the last few years change the way you're looking at Jewish-Arab partnership in Israel's medical system?
I think the major thing that we found in our research, and I'd be happy to share our presentation with you afterwards, is that the general concept was that good relationships, a shared mission to save lives, and diversity and inclusion efforts, or cultural competency, anti-racism policies and programs were sufficient to keep the system together. And it was a kind of closed bubble where politics or the external world did not enter. And I think the 7th of October broke that paradigm and requires a new paradigm to be adopted. And what we would like to suggest is that a paradigm of anti-fragility replaces or joins the diversity and inclusion tools and programs to provide a more resilient and a complete system that is able to cope with crises in the future. And unfortunately, these crises are bound to happen.
I think this would be a good time to share a little bit of the findings, to put numbers on and qualitative findings into what you're discovering or the tensions. Would you like to share your screen?
Yeah, so I'll share a presentation with you. Oh, hold on. And Manal and I will do the best that we can to take you through this calmly, focused, and quickly, and to expand on what you've heard from Abeer. And Abeer, thank you so much for sharing your experiences with us and laying the ground for us to take this forward into our research, our model, and our recommendations. And I would also like to use this opportunity to thank the task force team, the Abraham Initiative team in the States, and lots of our partners who I am happy that joined the call, the Sikui representatives, Yaela and Dr. Noor Shakhabri Abdelhabdi, the representative of the Ministry of Health. And we would like to all partner together in order to promote change. So I'll start with the existing paradigm, which we have more or less gone through, but just to give you some data. The health system was and still is by some considered a closed haven of Jewish-Arab coexistence, an example of a shared society, mainly due to the large representation of Arabs, 40% of the employees in the field, 25% of the doctors, 30% of the nurses, and about 50% of the pharmacists. So the leading paradigm up till the 7th of October was the fact that we are so diverse, that the relations are good, that we share a joint mission of saving lives, and that we have these diversity programs in place are sufficient to deal with crisis. The crisis due to Israeli-Palestinian conflict does not enter our organizational environment, and we are a safe haven. So on the 7th of October, as you heard from Abeer, and we heard from many more, this paradigm, I don't know if shattered is the right word, but proved to be insufficient. And so we decided to set out on a series of research programs to learn more about the effects of October 7th and about what had to be done. And so we used a multi-dimensional approach, multi-dimensional in the way that we used numerous methodologies, research methodologies, including a mapping process, qualitative, quantitative, and an analytical, theoretical approach to research. And we also used and referred to different timeframes. Before the 7th of October, we had a number of research projects that ran during the war. And our last, most recent research was a qualitative research that was conducted in December 2025, after the war kind of ended. And so I'll show you the main findings, and then Manal will take us through the theoretical, analytical research and the model, and then we'll complete with some recommendations. So the mapping we conducted about 8 months into the war, and what we heard when we talked about 30 people from the healthcare system and academics and employees and NGOs, and what we heard repeated itself when we talked to Jewish people, or mainly managerial positions. We heard that after the 7th of October, there was an immense increase in tension and hostility in the shared Jewish-Arab workplace, that they had to ensure operational continuity and ensure that everybody was provided with health care. And so they worked hard to and used everything they could to reduce the tension, ensure that there was no escalation, and ensure operational continuity. And when we met them, they were so fearful that if they touched on the Israeli Jewish-Arab topic, things would explode, or it would be like a Pandora's box opening and you couldn't put everything back, that they decided that it was best not to touch on the topic and to continue working. When we spoke to Arab employees, we heard a recurring story that is very similar to what Abeer described: fear, shattered trust. They were being accused of being the worst kind of enemy. They could not vocalize any empathy or support for people in Gaza, even if they were acquaintances or family members who were killed or injured there. And they went into survival mode, which basically included being silent. And all of the people, or practically all the people we talked to, said that they had thoughts about relocating elsewhere at that point of time. So our next stage was to find out what these efforts were that to ensure operational continuity. So we went into our second stage research, which was a qualitative research. And the main questions that interested us at this point was, were health organizations ready for this kind of escalation or crisis or tension between Jews and Arabs? And what practices did they use in order to prevent escalation? And what we found in this research was, again, that fear and hostility were prevalent in both the physical and the virtual spheres. Very often in the virtual spheres, social media, etc., it was even worse than in the physical spheres. And people had actually experienced what is now coined the term of digital persecution. It was mainly Jewish employees who filed complaints about Arab employees, about things they had published in their social media or said that were either offensive or offensive towards Israel or the IDF, or conceived as supportive of the Hamas. And the new practices that we saw established in the organizations to counter the tension and the hostility were resilience teams, sometimes only Jews, mainly management, sometimes Jewish Arab teams. We saw that there were interventions in Jewish Arab teams, mainly conducted by organizational consultants to mitigate conflict or reduce tension or let people create a safe place for saying how people feel. And we saw that many organizations implemented an inquiry process to deal with the complaints, again, mainly filed by Jewish employees against Arab employees. And here I must stress that most of the inquiry processes came out where the Arabs who had been the subject of the complaint were innocent. Okay. So to sum this stage up, what we found was that there was a lack of preparedness, even though as Israelis we have encountered numerous events of escalation of the Israeli-Palestinian conflict, that the efforts were responsive, they were sporadic, not systematic, and they were very limited in scope and in time. Had you gone into these organizations 4 to 6 months from the 7th of October, you would not see any of the practices that I spoke of, or very few of them, okay? So they were limited in the time that they were used. So then we wanted to see what was the extent of the phenomena we had found out in the 2 previous parts of the research. And we really wanted to validate what we had found and make sure that what we were speaking of was actually the actual thing. So we set off with quantitative research. This was a survey conducted in December of 2025, so it's very recent. We had 450 respondents, half Jews, half Arabs, diverse medical professions and organizations. And when we asked them about the tension and hostility between Jews and Arabs, as you can see, 60% of the Jews and the Arabs responded that they had experienced tension and hostility during the war. Note that the intensity of the tension and hostility amongst the Arab respondents is significantly higher than amongst the Jews. We then followed through and asked them, do you experience tension and hostility now? December 2025, the war has ended. And as you can see, 50% of the Arab respondents said they still feel tension and hostility today, whereas 72% of the Jews said that they were not experiencing tension and hostility to date. We continued and asked them about the extent of offensive remarks they had received from colleagues or patients from the other group, i.e. Jews from Arab colleagues and Arabs from Jewish colleagues. And then we followed through with the question about patients. And as you can see, here there's a significant difference. Practically 60% of the Arabs responded that they had been exposed to offensive remarks by their Jewish colleagues, 26% of them in high intensity, and 43% of the Jews responded that they had been exposed to offensive remarks by their Arab colleagues. When we asked them about patients, you can see that the picture is a bit more extreme, and 65% of the Arab respondents reported having been exposed to offensive remarks by Jewish patients and 37% of the Jews. We then followed through with a question that is more structural to see whether our assumption that there weren't relevant structures, or if there were, they weren't sufficient, were correct. And we asked, in cases of tension or hostility, did you have somebody to turn to? And as you can see here, unfortunately, the majority of both the Jewish and the Arab respondents reported that they had no one to turn to in case of tension or Jewish-Arab tension or hostility. So I'll sum up our research to this point. What you can see is that the work environment was experienced as very hostile. It was experienced as unsafe. And I think it is fair to say that the incredible ferocity of what was happening outside, the borders of the organization or the limits of the organization were not sufficient, and the tools that had been used up to this date, up to the 7th of October, were not sufficient to withstand the incredible and horrible impact of the 7th of October and the outbreak of war. And now I will let Manal continue with the next parts of our research and the model.
Okay. Thank you, Yana. Now that we have seen the data, we must move to our theoretical analytical research. Our analysis identifies 3 paradigmatic ruptures that occurred at the same time: the double narrative rupture, the crisis management rupture, the organizational rupture. This analysis reveals an urgent need for a paradigmatic shift, moving from DEI efforts toward a structured, embedded organizational models for shared workspaces. We are honored today to share with you, as a visionary partners, the model that we developed. But before speaking about the structures, let us speak a little bit about the ruptures, and I will start with the narrative rupture. As you can see on the previous slide, we are looking at a broken bridge. This is the double rupture in trust. The findings that Yana just presented alongside with Dr. Abeer's testimony and our field interviews reveal a painful reality. First, it is a rupture in the bridge of trust between Jewish and Arab employees. We saw this in the smallest daily interactions, as we heard from Dr. Abeer, the silence where colleagues stopped saying good morning, the segregation where break rooms became physically divided, and the suspicion where digital persecution and selective reporting replaced a professional partnership and years of friendship. The professional white coat identity was pushed aside by national polarization, leading to symptoms of organizational trauma and organizational moral injury. But second, it is a rupture in our trust in the old tools. We realized that our traditional diversity and inclusion models were too fragile to handle this level of pain, perhaps because they were not developed for such intractable, violent, ethno-national conflict. We understand now that we cannot mend a broken bridge of trust using the same fragile tools that let it collapse. So yet the question we must ask is, could we have been prepared for these painful consequences within our healthcare organizations following October 7th? To understand the gap in organizational preparedness, we must analyze 4 mental paradigms of leadership risk management leading up to October 7th. If we imagine the tension in Jewish-Arab relations on a mathematical scale presented across 2 axes, time and level of tension, we find the following mental paradigms. The first one is volatile cycles, as Dr. Abeer mentioned. Relations were viewed as the predictable waves. The beliefs was that after every peak of tension, a natural return to normalcy would follow. The second paradigm is accumulated tension. Leadership recognized that the baseline was rising from peak to peak. However, while the trend was visible, organizations failed to estimate the exponential intensity of the specific eruption. And the third paradigm is the gray reno. This represents a massive, visible, and inevitable threat. The risk was clear, but organizations prioritized immediate technical crisis rather than addressing the strategic risk within their shared workspaces. And the fourth one is the black swan. As described by Nassim Taleb, October 7th was a black swan. It is an outliner so extreme that this magnitude cannot be evaluated by the same metrics or scales we used for past events. It is a rare extreme event that reshapes history. By labeling collapse as a black swan, organizations often claim no model could have prepared them for such a total disintegration. So these 4 paradigms reveal the double fragility, the fragility of the system and the fragility of the DEI tools. We were operating under an illusion of prediction while the ground beneath us was shifting. So we must ask, could we have been immune to these painful impacts? Could we have built a system that does not just survive the storm, but grows stronger because of the storm? Many aims for resilience, but in our reality, resilience is often naive in our perspective. It assumes that we can just bounce back to what was before. But there is no before to go back. We need to rebuild our leadership, accountability, and our organizations and our societies so that the Black Swan crisis does not break us. Nassim Taleb's concept of anti-fragility gives us a new map of leadership. Based on mathematical principle of genes inequality, it tells us that convex system, the potential gain from uncertainty outweigh the loss. So fragile systems break under pressure. Resilient systems just try to stay the same. Anti-fragile systems, like the one that we proposing, evolve and benefit from stressors. They don't just survive the shock, they use the energy of crisis to grow stronger, smarter, and more unified. So this paradox of fragility is the heart of the organizational rupture. When the crisis hit, we discover our tools were too fragile. But as the saying goes, nature hates a vacuum, and In the absence of structured management, the vacuum was quickly filled by fear and hostility. And let's look at how this manifested inside the organizations. When we look at the organizational rupture, we must address the root cause, the absence of inherent managerial mechanisms. Instead of building an anti-fragile system, we saw organization relying on voluntary efforts, as Yana mentioned, outsourced workshops and ad hoc teams. These were not mechanisms embedded in the organization's DNA. Because of the lack of structure management, a vacuum was created. We saw ad hoc responses that were fragile by design, so mostly vanishing within 4 to 5 months after following October 7th. This lack allowed the outside atmosphere to dictate internal reality, turning national trauma into workplace hostility. The deeper failure was the lack of genuine shared leadership. Leadership cannot be based only on good intentions alone or tokenism. It must be anchored in clear rules and responsibilities. We need embedded structure, organizational mechanisms, an inherent managed framework that ensures that our organizations remain safe and unified for every member, no matter what happens outside. And this structure is exactly what the model that we suggest is provide. So to move from fragility to anti-fragility, we introduce the anti-fragile shared Jewish-Arab healthcare organizational model. This model is centered on management accountability. We rebuild shared workspaces through 3 deliberate structural pillars. These pillars are based on shared responsibilities, shared measurement, and shared decision-making. And the first pillar is preparedness mechanisms. We must stop the trend of underestimating strategic risks. Our preparedness includes mapping fragility drivers, internal factors that increase the vulnerability and the fragility of those shared spaces, shared workspaces, and create concrete scenarios and protocols to address them. And the second pillar is the cohesion mechanism. We focus on building professional organizational identity and shared authority and share the processes also of decision-making that are stronger than external pressure. This ensures that the team remains a single unit, even the outside would be polarized. And the third is psychological and physical safety mechanism. We need to ensure that every employee is protected from selective persecution or hostility or fear by structured organizational framework. This ensures safety and professional integrity for everyone. And by embedding these mechanisms, we move toward shared decision-making system where Jewish and Arab leaders manage the professional environment through the highest level. And now that we analyze the 3 fundamental ruptures, the double narrative rupture, the risk management rupture, and the organizational rupture, and I have presented the anti-fragile shared Jewish-Arab healthcare organization model. This model leads organizations toward anti-fragility within the shared workspaces, driven by managerial accountability and translating managerial accountability into organizational anti-fragility by preparedness, cohesion, and safety. And now I will hand it back to Yana to discuss the practical steps and policy implications.
Thank you so much. I know I want to take a quick pause because you both shared so much content, and I want to sort of take a moment and say that the research that you shared provides qualitative and quantitative affirmation of the experience that Abeer shared. And Manal, what you're talking about is a model that suggests management accountability. If Yana, tell us please about it in a few sentences, because I want to leave time for Q&A, how this is, what are the main aspects of interventions that we want to point to, and then we can open it up.
Okay, so I'll take us through our next slide and then remove the presentation. What we think needs to happen next, or our recommendations are, first of all, we have to treat the system as an ecosystem, and we have to create synergy between the regulator, the healthcare institutions, and civil society, us and all the partners on this call, and people who didn't join us. It has to be a collective effort. No singular effort will be sufficient. And what we recommend is to adopt the model or the concept of anti-fragility, and not to wait for the next crisis to happen, but rather to now take the time to build a policy regarding shared Jewish Arab workplaces, and to build the necessary mechanisms and to act together. So what our recommendations to the regulator, the Ministry of Health, are to initiate and implement this Jewish Arab workplace policy, to establish a good relations unit reporting to the CEO of the Ministry of Health, led by Jewish and Arab senior management. And this is incredibly important. It can't be a solely Jewish effort to ensure anti-fragility. It must be led by both Jews and Arabs, and to launch monitoring and learning processes, data collection, and to provide guidance to the health organizations. The health institutions, we think, the healthcare organizations should also establish a good relations unit, also reporting to the CEO of their organization, and it should also be composed of both Jewish and Arab senior managers who are accountable and responsible to ensure that plan, design, and implement mechanisms for preparedness, for cohesion, and for safety, to measure and report both to the CEO of the organization and to the Ministry of Health, and also participate in learning opportunities that should be provided. And our job, we hope, will be to consult and support leadership teams in the implementation of the units, of the mechanisms. Our job will be to collect data and translate information and knowledge into tools, into learning processes, into trainings, to promote anti-fragility, and also, when necessary, and now is necessary, to raise public awareness, and sometimes also to advocate for additional policy or anti-fragility processes or actions that might be needed. And my final words are from our most recent qualitative research. We can see, and you can see at the box at the bottom, that the employees of the healthcare system recognize that there is a tremendous need, and they want things to change. And I chose two questions to present here. The first one was, should the healthcare system strengthen relations and trust between Jews and Arabs following the war? And we have 82% of the respondents, both Jews and Arabs, responding that yes. And the second question was, do you support the establishment of mechanisms ensuring Jewish Arab safety in times of calm and crisis? And the answer again is, an 80% of the respondents, both Jews and Arabs, said yes. So there is a need and there is support, and now we have to together create a significant change.
Thank you so much. And I see that how much interest there is in this discussion. There are so many questions coming in. I want to invite Abeer to be spotlighted again to join us for the conversation. And I'll kick off and just say, so much of what you spoke about the research findings, the theory and the model for change relies on senior Arab partnership in the senior levels of the healthcare system. And before we open up for questions, I'm going to allow myself moderator privilege. Can you speak about, in your findings and in your experience, maybe, Abeer, when you have that kind of partnership, did you see the difference? Can you talk about the difference that it makes when you have senior people talking together at the top of the administration versus the voluntary ad hoc efforts trying to respond to crisis? Who can speak to that?
Lirona, I didn't hear the question.
Abeer, when you have so much of your work has been to promote senior, as CEO of the Forum for
yeah.
Workers, so much of your work is focused on promoting the presence of senior Arab medical professionals. In times of crisis, do you see the difference when you have senior Arab professionals taking account as part of a leadership teams? What does that look like compared to when that management partnership is missing?
Okay, maybe if we have more senior Arab doctors in administrations of our institutions, maybe we can handle it differently. Maybe this was give more ensure or something like بتحون safety for the workers. But when we don't have such seniors in the administrations, Arab seniors, the workers and employees felt alone and felt insecure and felt that the administrations search for their posts and statements, and this made them more anxious.
Can I add to that, Niran?
Yes, and I'll just say that I know we did reserve 75 minutes for this call, and so hopefully most of you can. There's many questions, and I want to make sure to get to them. Hopefully, most people joining are able to stay with us. Yes, Yana.
So two additional things. What we have to remember that on the 7th of October, the managers were also struck by trauma. I'm talking about the Jewish managers. I'm sure the Arabs were too, but the Jewish managers were also struck by trauma. Many of them had family in the area. Some of them have children serving in the army at that point. Some of them were drafted to the army. And so that's something that is incredibly important to remember. And in this kind of situation, I think in many incidents or where there was an Arab manager, he could actually function and go to the hospitals and address the teams and address the different needs and solve conflicts, and possibly take some responsibility where others were sometimes unable to because of what was happening and their other responsibilities. So that is incredibly important to note. Now, and in our research, we did find that there were numerous Arab managers who were not told to do anything, but felt responsible and actually went to the hospitals, went to the clinics, spoke to the people, both Jews and Arabs, tried to reduce tensions, solve conflicts, tried to ensure that Arab employees were protected because they were being persecuted, and they did provide a very important additional perspective to the mainly Jewish, mainly is not the right word, and according to Sikui's last research, I think it's 2.5% or maximum 3% of senior level management in the health system are Arabs. So the Arab manager's perspective is incredibly important for coping especially in times of crisis, but also in times of calm, Arab managers should be part of the decision-making process and should be part of the planning and the implementation.
Thank you. First of all, I want to share that a lot of these questions, I want to collect a few of the questions that are clarifying about the framework and about the realities we're facing. And I want to share that if we don't get specifically to your question, we are recording all of these and they give us a very good sense of what are the perceptions and what more resources we need to bring to the future, because I think this is an area that merits, that engenders a lot of hope, the medical system, and requires a lot of explanation about what it means to make system-wide change. So the questions I want to highlight, one is a clarification about how you're using anti-fragility. Because in the American context, it's often thought of as an individual, applied to individual or small groups, but here you're using it in terms of systems and structures. Can you confirm that? I see nods, but Manal, maybe you want to speak about.
Yeah. Well, the Nassim Taleb model is referring to anti-fragility as an organizational mainly. And it is about the systems that can gain from volatility and from disorder. And yes, like we are aware that also there is personal implications for the anti-fragility concepts. But in organization, it could be one of the principles of anti-fragility is skill.
Oh, we lost Manal's sound, but I want to just confirm that yes, you're talking. There's I think it's two different concepts that use the same term, and that there's an entire thesis around anti-fragility of systems.
Yeah, and one of the principles of anti-fragility in organizations is what we are talking about it in our model, is the role of leadership. And the first principle actually in anti-fragility is skin in the game of the leaders. They have a significant role in they are the genuine for this anti-fragility in their systems. So this is one of them. And a second concept that it is, I think it is very important to our context, is to move from the trap of predictability, because one of the paradigmatic ruptures that we identified in our research in the risk management is the trap of prediction. And one of the beautiful concepts of anti-fragility is to focus in preparedness and not in prediction, because the unpredicted will happen, and we cannot control it, and we cannot also be resilient to. And
I wonder if I can paraphrase that in the sense that in Israeli society, the reality of sitting on a basic conflict, basic tensions that are not resolved, it's actually more likely for escalations to happen than not. And even when they don't, these tensions are underlying every interaction. And so yes, the idea that I think before October 7th, so much headway was made on the basis of being able to put things aside. What happens when you put the tensions in the center and develop the capacities to deal with them? I want to respect how many questions there are coming in to keep moving us forward. So I want to combine a few questions. One is another question about anti-fragility is if part of your model is looking at incorporating this both in the training and the idea, it might be early days, but what application there is. There was a lot of questions about the commitment and the statements of commitment and the oath that medical professionals take, and if that has relevance to Jewish-Arab relations. And third, I also see questions about whether this is really about between medical professionals or patients and medical professionals.
Yeah.
So if you need me to repeat any of those, or I see a lot of nodding, Yana, if you want to comment, Abeer, if you want to comment about any of these questions. Yana, do you want to kick us off? And then Abeer, I'll come to you, maybe talk about the oath and the relation that between doctors and between patients. But Yana, maybe you can start with anti-fragility.
I'll start with the first question about training, and then you take me through a few of the others, okay? Yes, obviously we have to reach the training stage. That's one of, I think, one of the most important stages. If we start talking about the shared Jewish-Arab workplace and the fact that there are patients of both kinds within the workplace, instead of ignoring it, then obviously people will get into the system with ideas about how this shared workplace should look, how they should behave, and it should definitely be part of training, and it should definitely be part of managers' courses. There shouldn't be a manager in Israel who doesn't go through anti-fragility or shared Jewish-Arab workplace sessions in order to learn what is expected from him or her and what tools are available and how to respond to different kinds of scenarios that do and will happen in the future. And I think part of that, and I'm just touching on the question that Abeer will answer, is that the ethics question is incredibly important. And that should also be part of the anti-fragility or preparedness mechanism, because we know that we are going to encounter ethical questions, severe ethical questions, both regarding us being a shared Jewish Palestinian citizens of Israel team, and both regarding what happens in the West Bank or Gaza. So let's deal with these questions in advance and understand how we're going to cope with these scenarios and what's expected from us.
Thank you. And Abeer, I don't know if you want to talk about the experience of what kind of commitments you make becoming a doctor in Arab society and how that relates to the ethics and ethos of equal treatment for all and how that plays out. You maybe start there and add how you experience the relations between doctors and between doctors and patients as and where identity comes in to play with that.
Okay, I will start about the relationship between the staff and the patients, mainly the Arab staff and the Jewish patients. We saw many events of disagreement of Jewish patient about getting care from Arab professionals, nurses or physicians, and this affects a lot the system, because if we talk about 40% of the staff is or Arab staff, so if Jewish patient don't agree to get care from an Arab professional, it harms and affects negatively the competence of the system. In regarding of our training.
So you're saying there's a public awareness role and there's a potential role for the medical system to facilitate this. I just want to comment that it is the close of the top of the hour. We really hope people stay with us. If not, a recording of this full session will be sent. And I hope, if it's okay with the three of you, that we'll share some of these questions that we're not able to get to, and maybe you guys can provide a summary response that we can share to everybody, to the main points we don't hit. Please, Abeer, continue.
Yeah, so physicians during their medical education educated to give care to all people regardless of their religion and nationality. All our patients is equal, and for each of them deserve to get our best care and treatment. We felt that this wasn't the case during the two last years, and I suggest in summary, I suggest that the hospital should educate the doctors and the physicians again, and to get them remember their swear when they swear that they will treat everyone and take care of every patient. There was many events of arguments about what minimal care can we give to a Palestinian guy or patient who came from Jenin or from the West Bank. You can feel uncomfortable and unpleasant, and you can feel anxious about your colleagues that you had to be friends and partners on giving the care, and they can make discussions about what minimal treatment we should give because he's Palestinian or he's not Israeli.
Thank you. There are also questions getting back to the technical experience and what's different now. What learnings are there from past crises? This is, you spent some time explaining why October 7th is a black swan, but there have been other escalations that, Abeer, in the beginning, you said they came and went, but I'm wondering if, Yana, in your research, you discovered, people spoke about those, and if there are any roots to pull from in thinking ahead.
So what we found in this was the qualitative part, was that though many of our interviewees said that they had learned, let's say, from the last big event being May 2021. So many people said that they had learned from May 2021 and the tremendous increase in tension, both in the public sphere and inside organizations. But only 2 organizations that we spoke to had actually established some kind of team to deal with tension. So the majority, you could say, had implicit knowledge about what happens in times of tension, but did not actually make any practical, it didn't have any practical implications. No team was established, no protocol was established, no thinking about what happens next time we have incredible tension due to something going on outside. And the 2 organizations that did do something, it was also a limited team. The team was established after 2021 in one of the organizations, and then it ceased to function, and then only started functioning again in October 7th. So they had some kind of structure and but it was also a limited team of 5 people, okay, dealing with thousands of employees and thousands of patients. And the other organization that did something following May 2021 established a kind of a Jewish Arab voluntary forum that was very helpful in kind of providing guidance or thinking about things or taking small actions, but it was voluntary. and it was not part of the structure or the system or the DNA of the organization. And this is the kind of thing that we would like to change and make more systematic and a part of managerial accountability.
Before we close, we'll ask about what status these efforts are in. But one thing we haven't spoken about yet that I really want to get to, and is also at the heart of one of Abeer's many jobs, is health outcomes. Abeer, as CEO of the Forum for the Health Promotion in Arab Society, you've been linking the idea of promoting Arab doctors into leadership positions and developing this high level of partnership at the top to health outcomes. Can you say a little bit about about why the tension in the medical system is not only about social cohesion? How does it impact healthcare quality in Israel?
Okay, we face a significant disparities in health outcomes between Arab and Jewish people in Israel. And we think one of the causes for these disparities is that the system doesn't have sufficient leaders and decision makers from the Arab society who knows and who lives the Arab society culture, who knows that what obstacles they have. So when we as Arab professionals and Arab doctors, when we are not partners, not act as partners of decision making and impeding policies in the health system, we cannot. The system cannot close and overcome these gaps and disparities in health outcomes.
Manal, Yana, I don't know if you have something to add to that.
Yeah.
Yes.
Yeah, I would like to add that we need to move from efforts to structured mechanisms, because our healthcare systems are experienced. Okay, they are experienced from the past, from previous escalations. But they cannot rely only on sporadic efforts or on voluntary efforts or outsourcing the need to mend the ruptures among within their organizations by relying on the efforts of DEI organizations. Those efforts are very important, and many of them also very effective. But they don't cancel the need that those efforts need to be embedded in the organizations, because it is the managerial accountability and the leadership accountability among those organizations for those teams, psychological safety and physical safety, and this is the managerial, also the leadership accountability is to make these spaces, these work spaces, possible for the teams that at the end of the day, the majority of us, we are not doctors saving lives, not like in usually basis and not under fire, but I think that it is our duty to ensure that those teams, while they are doing their work, can feel that their organizations are behind them and can support them. And the efforts of the DEI organizations are additional efforts, but the main efforts need to be within the organizations themselves.
I want to, starting our closing thoughts, I want to reinforce something you just shared, which is that, and what you started off with, how for so long the medical system was seen as a DEI success effort, and it was thought about as Jewish-Arab partnership in the workplace. And today, with all of these crises, it's looking at the partnership to support this, an essential set of institutions in Israel, and what that looks like. And first of all, thank you so much for doing the thinking and providing a paradigm that is in some ways deeper, and bring some of the realities in. I want to ask you now to talk a little bit about where you hope this research and the civil society efforts, what the status is of the model and the interventions you're suggesting, what are your next steps? And Yana and Manal, you can speak about the research and intervention model that you're suggesting, and Abeer from the position of the CEO of the Forum for Promotion of Healthcare in Arab Society. So maybe in order, I see Yana, Manal, Abeer. We'll give you the closing words.
So we've just completed the research, and you are actually the first forum who we present our model to. So we've got a lot of work to do. Our next step, we hope, will be presenting our research and making the case for the model and for a change in policy and implementation with the Director General of the Ministry of Health. And we would also like to present our research and model to the head leadership of hospitals, healthcare clinics, and to get their support to start the change. And then we would like to be the organization that supports and consults these efforts in implementing the necessary change, focusing on the establishment of these good relation units and the establishment of mechanisms. And when we say mechanisms, again, we mean roles and responsibilities, processes, decision-making processes, measures, and reporting.
Yeah, and additional to what Yana mentioned, also we are going to share our thoughts and our understandings with visionary partners, and to hear from them, and also to learn from their experience. What we also understand from the field that those thoughts that we have after our studies are relevant not only for the healthcare system. It is relevant also to another systems, like it could be also relevant to what happened in the universities and also in companies. So it could be also useful and efficient to hear from different fields. But at the end, what we aim to see is that this model is implemented at the top managerial levels, and also in the ground, translated to organizational units with the R&R responsibilities and rules, and also with the organizational policy and risk management policy, which is in daily basis, and also to be prepared for the future, because we aware that while developing our model, we also develop the basic assumptions of the model. And one of the basic assumptions that we are live in a reality which include ongoing violent ethno-national conflict, and this conflict affects what is going on in the organizations. We are not surprised of that, and and unfortunately, this is our reality, and we need to be prepared for that.
I really hope that in a few years we'll be able to look back at this moment and say, wow, look at how institutions developed a model to withstand this reality, and that both the medical student and this model was able to be replicated even elsewhere to create greater antifragility. Abeer, the last word to you.
Yeah, I want to say that we at the forum felt and saw
Again, please mute yourselves if you're not a speaker. Thank you. Go ahead, Abeer.
So I started saying that we at the forum started a pilot of a workshop of resilience. We started a national workshop for Arab health workers to evacuate this anger and this anxiety and this fear, and to talk about thoughts and feeling, and we had people who cried there, who talked about their future, their children's future here, that their career. It was so sad what happened in these workshops, and we have plans to proceed with binational workshops for Arab and Jewish staff together, because if we don't let the people talk about thoughts and feelings and share these thoughts and feelings together and get knowing each other and strengthen the acceptance between the people, we cannot build a competent system. And every conflict we face in the future, we will return to this point of fragility. And something that was so significant for us, that we will start with a Weizmann Faculty of Medicine, talking about a culturally competent education to medicine students at their first or second year of studying medicine, and to get people, Arab and Jewish students of medicine, get know each other and accept each other and share thoughts and feeling, and to get all of them know and believe that we all together, we don't have another home, we don't have another land. We must find the way to get together, to live together, to keep our peaceful environment and workplaces, and really to be one nation.
Thank you so much. Those are really, couldn't have asked for better closing words. I want to reinforce that you both answered some more of the questions from the chat about the training, and gave us a concrete example of what such ad hoc initiatives that come from strong leaders such as yourselves do in certain islands of the medical system, and shows the potential of what scaling this up and creating policies and practices that create that opportunity across the system might be able to do. Thank you, all three of you, for your time. Thank you for everyone that stayed on, and for all of your questions. We will take the questions, share them with our speakers, and not only will we share this recording, this is an issue we'd like to come back to for its potential and as a model, and because it is so vital for Israel, for Jewish-Arab relations, and for the hope that we all need today.
Thank you.
Thank you.
Thank you very much.
Have a good evening.